So I really want to thank you, Carla, for the introduction, and I really want to thank Perry and Carla for organizing this whole thing and putting it together. I actually love being in Houston. I come here at any chance I can because my sisters and their families live here. So anyway, it's really great for me to be in Houston. I grew up in Houston. So went to high school in Katy. So I'm just back to my old stomping grounds. All right, so I'm going to be talking with you about childhood precursors, predictors, and risk factors today. I'm going to try to tell you what I want to convey is the distinction between what a precursor is, a predictor, and a risk factor. And then I also want to point us in the direction of what we should be trying to target and identify in order to increase prediction accuracy. So Carla talked a lot about how to assess borderline personality disorder in adolescents, and I think that's incredibly important. And so then the issue becomes, what are the risk factors that we could use to identify those kids even before they onset to the disorder, right? So what are the tools that we would need to know, what information would we need to know to say, yes, this child is at very high risk and they need an early prevention, they need an early intervention or prevention program. And so that is what I'm very much interested in. And we'll be talking about sort of the strengths and weaknesses of using these different types of factors. And then I'll also tell you what, using the PGS, the Pittsburgh Girls Study data that I have to demonstrate a method that we can use with these longitudinal data sets to actually start to identify and think about what the precursor profile might be to say, yes, this child, though, they definitely have these precursor markers. That means they're at very high risk, and they're in this special group then that should receive early intervention or prevention services so that they don't go on to prevent the development of the disorder. Okay, so I just want to disclose any potential conflicts of interests, and I will say that this is just all funding my research. I don't get any money from pharmaceutical companies or anything like that. Okay, so why do we care about preventing this disorder? Well, I think we should take a step back and just remember why it's so important to prevent it from the onset. It's because the consequences of having the disorder in adulthood and in adolescence are incredible. The cost to the individual, the cost to the family, and the cost to society cannot be understated. BPD is one of the few psychiatric illnesses that has such a high suicide rate. The only other mental illness that has a higher suicide rate is chronic anorexia, which has a very high lethality rate. But BPD has a very high suicide rate. And so we want to prevent kids from having that risk. It's also associated with really high rates of costly treatment utilization. So on average, a person with borderline personality disorder will spend approximately 6 days in a psychiatric inpatient hospital and have 1 ER visit per year. That's just on average. So of course, some people utilize much more, some people utilize less. And I would just predict that as the person with BPD continues to receive ineffective treatment or doesn't receive an effective treatment in the beginning stages of the disorder, they are going to be at increased risk of utilizing even more ineffective and costly treatment resources. So it's really important that we can prevent that from happening. And then the chronic psychosocial impairments that affect the person, their family, their ability maybe even to have a family, and larger society, is that people with BPD have a really hard time maintaining work. And Freud, work and love, right? That is what life is about. So not being able to work is really problematic. I mean, it's hard to organize yourself if you can't work. I think Mary Zanarini said that work is IOP, an intensive outpatient program for people who aren't in psychiatric care. So it's really, really important. And patients who have a diagnosis of BPD even after they remit from the disorder, meaning they no longer have the disorder, but they did at one point, they continue to have very high rates of receipt of disability payments. 40% of people who have remitted from BPD in 2 longitudinal studies have been shown to receive disability payments after 10 or more years of follow-up. So this is why we're here. This is why we want to make this such a important topic to study. So, all right, so what we know about borderline personality disorder, the majority of the research is focused on adult samples. And as Carla mentioned, the rate of research in the early stages, adolescent development in BPD has really taken off in a really short period of time, so like past 10 years or so. I actually remember this special issue that changed my life, 2005, where Journal of Personality Disorders put together a little series on longitudinal studies of personality disorders like in children. So it represented the children in the community sample and a few others. And I was just so excited that somebody was actually articulating the exact thing that I wanted to study, because I was a graduate student, so I was a little intimidated to sort of say what I wanted to do. But anyway, it was really amazing. So that was 2005 when that came out. And so the problem with identifying or just looking at this in adults is that the typical onset, though, we think, is in early adolescence. And so we're really missing the period of peak prevalence of the disorder when we focus on recruiting adult samples. We're also likely to recruit samples for research purposes who have had the disorder before, so they're kind of scarred by their previous disorder, right? Or maybe they're a more severe form even. And so I think it's really important to look at people early in development, around the time of peak prevalence, so we can understand a little bit more about what is going to predict the onset of the disorder. So here is a very simple pictorial picture of what the developmental course of BPD looks like when we look at age-based trajectories in community samples. So as Carla also had a graph sort of depicting the same thing I want to illustrate, that we can see the disorder onsets in early adolescence. We have validated measures for assessing and diagnosing borderline personality disorder beginning at age 11 currently, and that it peaks in mid to late early adulthood, emerging adulthood, okay? And then in mid adulthood, past probably 30, the rate of onset is really going to go down. So this is kind of the course. And so, we have made several important advances in understanding the development psychopathology of this mental illness, and so and the typical trajectory is one of them. And we also have identified several risk factors that predict increase in the rate and in the trajectory of the symptoms. So, for example, kids who have high levels of emotional reactivity, we would expect that their trajectory of borderline personality disorder symptoms from adolescence to adulthood would be elevated compared to kids with low levels of emotional reactivity. We also have identified some important contextual risk factors that also further exacerbate this course. So kids with emotional reactivity and high levels of family adversity, they have even higher levels. We would expect their developmental trajectory of BPD symptoms or likelihood of having the disorder to be even higher. So my research has focused on understanding the developmental course of borderline personality disorder in a high-risk community sample primarily. And I'm also interested in identifying those early risk factors and precursors that will prospectively predict BPD in adolescence and young adulthood. So as I've been saying, that is required to ultimately prevent the onset of the illness. We have to know who's likely to onset, and then we can understand not only to identify those kids, but then also to start to look at the processes, the mechanisms, biologically, environmentally, at all levels of why some kids with that high-risk profile will go on to have the disorder and why some kids will not. And that's important to understand the etiology, the pathophysiology of the etiology, the onset of the disorder, so we can understand like what is happening under the skin, as Carla said, to make these kids who are at risk actually go on to have the disorder. Oh, and I wanted to say one thing. So if we think about these terms, predictors, risk factors, and precursors, these are terms that are describing factors in the individual or the child that that result in an increased likelihood that that person will have borderline personality disorder. And so predictors and risk factors and precursors are different in how unique they are to the eventual manifestation of the disorder. So a predictor might be something like, let's say, low income, family low income. Now, that is going to be really broad and actually going to apply to many, many things. It's going to also predict things like depression, conduct disorder, all sorts of psychiatric problems. And then precursors, on the other hand, they are really, really specific. Like what we want to demonstrate, what we really want, are early markers that predict BPD, but don't predict as well the onset of depression, right? Because that will say, okay, these kids are at risk for BPD, and this profile really doesn't indicate they're at risk for depression. And that's what we really need to know. So here's, from most general risk, and then you can come down to sort of the precursors at the precursor level. And then on the right-hand side, I'm just trying to illustrate that this is also in relation to usually time to onset. So we can't measure signs and symptoms or precursors of borderline personality disorder in infants. We can measure mentalizing capacity in toddlers, but that is going to be something, way back in their developmental history. It's not going to be something that's going to predict onset in the following year. And we can't assess emptiness in infants because maybe because they don't have mentalizing capabilities yet. So we have to understand how those sort of things interact in terms of like when are we examining things developmentally, and then what's possible in terms of identifying really a high-risk group. So that means we can identify precursors in, probably, let's say, 10-year-olds, because usually we want to look at something that's close in time to onset. So to the peak prevalence when we would expect people to start onset. So psychosocial adversity, we see that's very general. And then you get to maltreatment and trauma, which is also a general risk factor, family factors, child factors that are, now we're getting a little bit more specific, and then actual signs and symptoms of BPD. So we could look at, did that person endorse emptiness at age 10? Did these people endorse emptiness? And how well does emptiness go on then to predict which kids are going to actually onset to the disorder the next year? Oh, and there are a couple of citations of people doing similar things like this. All right, so here's significance of why we care about precursors and what they are. So precursors are going to prospectively increase the likelihood of BPD. So that means they have to occur before the onset of the disorder. And it will help us identify high-risk individuals. So in order to do this, we need short-term longitudinal studies that have repeated assessments of BPD symptoms and processes, mechanisms that we think are related to symptoms, the precursors, and the disorder onset. And this will help us to identify those kids who are indicated for prevention. And we need to intervene prior to the full-blown disorder. So if you're administering, the BPFS, and the child is, what was the CUT score again? 66. Then it's too late, right? Like you missed your opportunity. So we really need to do this before they get that score of 66 on the BPFS. So my postdocs and I painfully conducted a systematic review of the literature. I do not recommend this. I thought it was going to be really fun, kind of like knitting, like you get into this like groove and it's like therapeutic or something. No, it was not. It's very frustrating because we identified 358 articles to be included, but our search actually started with something like 10,000 that we had to go through. It was not fun. But we did it, and I'm really glad we did. And this is going to appear in an upcoming section in PDTRT, and Carla has a paper there too. Other people who have who work in this area, so it'll be a good issue to check out when it's actually published. So what did we do? We searched the literature. We limited our search to studies that were longitudinal and observational in nature because we did not want to look at studies where treatment was introduced or had been introduced because that would that would mess up our observational, the idea that this precursor would lead to that disorder kind of thing. And we wanted to identify those studies that had looked at predictors that were they had to be prospectively identified. Many studies we rejected because they were cross-sectional, like maybe BPD onset and the predictor was measured at the same time. Or BPD had been identified, and then, 10 years later, they said, oh, well, how did, their reports of sexual abuse at age 5 predict? And they asked them about sexual abuse at age 5 when they were 25. So that kind of study would have been excluded because we want to, again, for purposes of for clinicians and for practically, like, how do we get this group? We cannot rely on retrospective reports. And then the outcomes had to include things like diagnosis, symptoms, traits, or features of BPD. Identified 358 articles that met these criteria. Then we screened these articles even further. We did a title and abstract review and excluded 309 because they did not meet these criteria. And then we actually read 49 articles and did a full manuscript review. We read them and carefully debated, like, does this really meet our criteria? And we excluded 11 from that. And so there were 38 articles in our final analysis. And so then we extracted predefined data fields, like we recorded things like study characteristics. We recorded how the risk factor and outcome were measured and any findings they had. And so myself and 2 postdocs, we did this. We rated every single one of these papers in these little fields. And then we determined if there were any discrepancies. We just decided by consensus. The review decided that by consensus. So in terms of those 38 papers that we systematically reviewed, here are the numbers that were published in each year. There was one paper that we included. It was published in 1993. And then, you can see that the majority, though, of these papers were published since 1993 identified. Anyway, the past 5 years, we've seen a huge number of published papers in this topic. And I think a lot of this uptick actually might be accounted for by that JPD special section in 2005. Because look what happened in 2005. Really took off. I was still in grad school. I had nothing to do with that. But I just think could have been. Okay, and then if you think about looking at the type of outcome that these 38 studies had or included, so, were they looking at predicting BPD diagnosis, symptoms, or features? Most of these studies were predicting symptoms. A few predicted diagnosis, and a few predicted traits. They called them traits or features, and it was not really possible for us to tell by the way the researcher described their measure whether or not they were actually assessing the symptoms. So I wanted to keep that separate in case it had any influence on our analysis. So now I'm just going to review for you what we extracted, these broad themes that we extracted. The papers were so diverse. I mean, there's really not a lot of information. If we looked at something similar to like depression, we could do lots of meta-analyses. I could not do a meta-analysis because the outcomes were too different, the predictors were too different. But over time, we will be able to do nice meta-analyses for you. But this is a systematic review, so it's more like a qualitative design. So we identified psychosocial adversity and maltreatment as one risk factor that was routinely studied and also was usually predictive of BPD outcome. So one of the family characteristics was limited family resources, and that included things like poverty, low maternal education, single-parent households, stressful life events. Do you think that just predicts BPD specifically? It wouldn't predict depression? Who thinks this would predict depression and BPD? Yes, it does. It does not just predict BPD. It predicts all sorts of psychopathology and just poor health in general, right? This is, poverty is very costly. And then childhood trauma was also another variable that we identified that many studies looked at. So these included things like neglect, verbal abuse, physical abuse, sexual abuse, and early maternal separation, multiple moves for a caregiver's new partner. So what this means is the family, usually the mother, would move many times in like a period of 1 to 2 years to move in with new boyfriends, right? And so the kids would come with them, kind of thing. That was the risk factor there. And then any kind of perinatal adversity, we just kind of lumped that together because there weren't that many at all. So wait, what was I going to go? Oh, so here's just family adversity. So that first kind of risk factor. This is a paper that we did. You can't see the bottom of the slide too well, but this is a paper that we did where we looked at family adversity, just broadly speaking, and how exposure to that moderates the effect of negative emotional reactivity on BPD symptoms. And what you can see from this graph is that for children who had, adolescents at age 16 who had high levels of negative emotional reactivity and high levels of family adversity, that in this community sample, they had on average, 4 BPD symptoms at 16, 17, and 18. And if they had high negative emotional reactivity, but low family adversity, they started out with high levels, and then they did decline a little bit over time, but you still see a main effect, a big difference, right, between those kids. These are girls who had high levels of negative emotional reactivity versus low at age 16. And then if we look at the girls who had low levels of negative emotional reactivity at age 16, they overall had pretty low, right? Pretty low levels of BPD symptoms on average across this developmental window. So, between 1 and 1.5 symptoms, that was on average. So not many at all. And then we also identified a big group of factors related to family and parent and child risk factors. So we have a category of parent-child relationship, and that included things like attachment to caregiver and poor relationship quality. And then parenting behaviors, usually they were divided into emotional kind of qualities of parenting, which is low warmth, control through guilt, and then behavioral parenting strategies, high behavioral control, harsh punishment, and intrusive and inconsistent parenting. And then for the child factors, we identified temperament and psychopathology as something that's routinely assessed. And negative affectivity and behavioral under control were routinely identified as a temperament or personality predictor. Again, this is not going to be specific to BPD. It's just indicating risk for general psychopathology, most likely. And then psychopathology, child disorders, child onset disorders, internalizing problems, depression, PTSD symptoms, and dissociation in childhood were related to BPD in adolescence or adulthood. And then externalizing problems of ADHD, CD, ODD, and substance use. Those things also predicted BPD. I think, if we think about that pyramid, the inverted triangle, I guess, the things that we're reviewing are getting more specific, right? So we would expect these child onset disorders to maybe give us a little differentiation, maybe, about who's going to onset to BPD versus depression. But we would not expect it to do a great job when looking at things like family adversity, in terms of discriminating who's going to predict depression versus BPD. And here's just an example of a paper that we did looking at the pattern of prospective associations between childhood onset diagnoses of ADHD, ODD, and then looking at age 14 BPD symptoms. And so from ADHD, this ADHD trajectory of symptoms predicted BPD at age 14 and also CD. But but what you can see what's really interesting to me is that the increasing trajectory, so symptoms of ADHD that were increasing at every year, so we assess these kids every year from 5, they're now in their 20s. So when we assess them every year from age 10 to 13, we saw that the kids who, for the girls who had increasing rates of ADHD symptoms from 10 to 13, that was predictive. That was specifically predictive for just BPD, but not depression or CD. And similarly for ODD, increasing ODD symptoms from at age 8 to 10, that was uniquely predicting BPD at age 14, but not depression or CD. So again, this gives us a hint. Maybe it would be useful to track kids' symptoms over time and see not only like at one static point are they elevated, but what are their rates looking like? What is their profile looking like, and how does it change over time? For kids whose ADHD symptoms and ODD symptoms are increasing during maybe these windows that at least we have identified here, that might be indicative of specific risk for later BPD. Now again, I don't have the cutoffs for these things. This is where we'll have to do more work. Like, what could I tell you to take home? And like, well, if it's 4 this year and then it goes up 2 symptoms and then that's the kid. I can't tell you that yet, but we'll get there. All right, so here's the summary of what we found in terms of this review. So the predictors really focused on the usual suspects. There's nothing really, nothing to write home about, oh, this is the thing that's, distinguishing BPD. We could look at these things with all sorts of outcomes for the most part, and we would expect to find increased risk for psychopathology. They were usually very distally measured compared to the BPD outcome. So when you look at a perinatal factor, and then when you assess BPD in mid-adulthood, that's a really long time. A lot of stuff happens between them. So those kinds of studies or that kind of factor is not really going to help us to understand the pathophysiology leading up to onset, like right at that moment. It's going to provide us less information. It's going to provide us a lot of information about what would happen before, but it's a really long developmental cascade to try to parse. And then few of these studies controlled for third variable influences. It was really surprising to me how many papers did not control for expected things that would influence both the relationship between that predictor and BPD. So when you don't control for, if you have a sample that's very impoverished, you don't control for poverty when you're looking at things like the relationship between CD and BPD. That correlation between CD and BPD is going to look inflated. It's going to look larger than it actually is because that influence, that family poverty really does explain some of the variance, some of that association between CD and BPD. And then there were very few studies that looked at contextual information. So for example, none of us develop in a vacuum. None of it, our biology is always interacting with the environment, and so we really need to understand, another sort of objective is to understand for what child, but in what context, right? So what process in what context is going to increase risk, and there was very few, we had very few papers that examined that. So the outcomes that we found that in these papers, they primarily predicted symptoms. Few of the studies predicted disorder or disorder onset. Few even had an extreme group as an outcome, and I know why. I'm definitely one of the people who I don't do that, because when I artificially, if I have a continuous measure and I decide to chunk it into two, like just two groups, I'm going to lose a lot of power to detect effects. And so that's usually not what we do. But I think for some methodologies, for some purposes, it might be really useful. These are the things I've been thinking about. And then we also don't know at what stage of the illness individuals who were in these studies represented. So let's say we were looking at a study where people were predicting the disorder. Well, we don't know how many of those people had just onset in the past year. We don't know how many of them had the disorder for 5 years. And we don't know if this group, if there's a group of people who are on kind of the uptick, like their symptoms, they're actually getting worse. We're catching them then, or we're catching them at a time when they're actually improving and getting better. So by not accounting for or considering where this illness stage, so not just, I think we have to move away from just thinking about BPD in adolescence, because yes, BPD does exist in adolescence, and we have to attend to this developmental parameter of the disorder itself. We can't ignore that, because that's going to weaken what we can understand about the pathophysiology, the mechanisms that are going to lead to onset. And these other stages too, which are equally important to research in terms of maintenance, exacerbation, remittance. And then lastly, few papers looked at outcomes besides BPD. So I don't know, I can't tell you from these papers, were there any specific predictors or specific relationships between any of these predictors and BPD, because most of the studies did not look at that. Most studies just predicted BPD. And so, I can't say, that they didn't or they did. So that's a really problem. I think what we need to do is include many different types of psychopathology so we can understand, is this specific to BPD or not? And it's okay if it's not. We just need to understand, why, and it's going to help us understand why. And I also think one of the reasons this had to be this way, we had to start with only predicting BPD, is because, as Carla mentioned earlier, many people are resistant to thinking that BPD exists in adolescents or can be diagnosed. So we have to demonstrate that the disorder is a valid one. And the way to demonstrate that it's valid is to do things like she did with that same thing with the assessment measure, to look at, is this operating the same way that depression does? Because depression in kids we believe in, we think that's real. So if BPD acts the same, is acting in a similar way, then okay, yeah, that's evidence suggesting that there is convergent validity there. Okay, and then the other thing that we have to keep in mind is that the results were concentrated within few cohorts, meaning like few groups, few big data sets were used to examine this prospective evidence. And so primarily studies come from the Children in the Community study and then from the Pittsburgh Girls study. Those two sources contributed 29% of the articles that I reviewed. And so I think we just have to remember, I just have one data set. And the girls that I have in Pittsburgh, I think they're probably pretty similar to the girls in Houston, but I don't know. I don't know if they would be different. So we just have to keep that in mind too. Okay, so we've already seen this slide. I'm going to move on. Okay, so I mentioned that it's really important to move beyond just thinking about ages. We have to consider age. We need to consider an additional parameter, which is the disorder, the development of the disorder itself. Oh, yes, okay, so we don't know which pathways are distinct for BPD. We don't know which stage of the disorder they predict. And we also, in addition to predicting things like disorder, we might also want to predict symptom onset. So what predicts the onset of the symptom of emptiness? We could find out. And that might also help us to understand different pathways that kids can take to get to the disorder or away from it. Okay, so in order to increase prediction accuracy, I hope I've convinced you that we need to be able to identify these precursors. And this is what people in schizophrenia research did many, many, many years ago. So at one point I had a lot of fun reading schizophrenia articles from the 70s. That was fun. And so people have been doing this for a long, long time. And I could talk at length about why I think we haven't done this in BPD, but you can ask me about that later. All right, so we need to first, to identify these precursors, we need a sample of kids, we need a sample of people who are assessed repeatedly at the period at which we expect the disorder to have peak prevalence, peak onset, okay? Because what we have to do is we have to say, okay, so we can look at all these if we look at these childhood precursors, so some of these kids will have precursors of the disorder, and some will actually have the prodrome. Now, a prodrome, for people who may not be familiar, is just the early stages of the illness. So these are the kids. It's like what these kids had the disorder, and the year before, they may have been in a prodromal phase, like that was predicting that's going to lead to the disorder. But a lot of the kids who had those symptoms may also have just gone on to develop depression or maybe fine, and those kids would not have had the prodrome. They would have had a precursor. Okay, so they may have a separate set. So we have to use these longitudinal data. I'm going to use this longitudinal data set to try to identify those kids who had an onset of borderline personality disorder during adolescence, and then I can say, okay, what did their prodrome look like? What did their prodrome look like a year before? And how does that compare to, is that really a prodrome? Because does it also just predict depression or CD? Or is it just uniquely predicting BPD? Okay, so to identify this in the girl study, we used the girl study, which has repeated assessments during adolescence of BPD symptoms. And so we want to identify, and then again, I wanted to identify what were the prodromal periods after the onset, and we would examine signs and symptoms immediately before the onset of disorder to identify the precursors, and then I examined the specificity of the relative risk to BPD compared to its risk for depression and CD. Okay, so the Pittsburgh Girl Study, I've alluded to it a couple times. I'm going to just describe some basic methods. The Pittsburgh Girl Study is a large urban community dwelling sample of girls that were identified in the city of Pittsburgh, and we enumerated the entire city of Pittsburgh in 1999 and 2000. We sampled 100% of low-income neighborhoods, literally a household enumeration like the census. They would go around and ask, is there a girl living here between the ages of 5 and 8? And if there was, great, would you like to be enrolled in this longitudinal study? Only going to be 5 years, foot in the door, because we're at year 17 now, but yes, 5 years. That's all we had funding for at the time. And then we sampled 50% of the remaining non-low-income neighborhoods. And so in sum, we sampled 103,238 Pittsburgh households and identified 2,876 5 to 8-year-old girls, and 2,450 agreed to participate. And so we were able to recruit 85% of all of the girls who were living in Pittsburgh between the ages of 5 and 8 at that time. And our enumeration converged very nicely with the one done by the U.S. Census in 2000, so we're very happy with our efforts there. We do think we found all of them. We actually think we did a better job in the census, but we won't get into that. Okay, so this is an accelerated longitudinal design. We have 4 age-based cohorts with about 600 girls in each cohort. And this just illustrates the years with the dash, meaning I can't fit all of them on one slide. So it's annual assessments. So 5, 6, 7, 8, 9, 10, 11, 12, right? All the way, and now our oldest cohort is 22. We're in wave 16, annual assessment 16. We're finishing that up. It'll be finished actually in about 4 weeks. And we will start phase 17 in August. Yeah, I think that's really great too. They agree. Okay, so the